So I'm the token laboratorian. I think all these type of symposia you have to have one laboratory person here, so that's me. So I don't have any disclosures. I aspire to have disclosure someday, but not yet. So my objectives are fairly simple. We're going to talk about the pre-analytical issues, the analytical issues, and the post-analytical issues dealing with urine cultures for the diagnosis of urinary tract infection and other tests too that may kind of fold into there. So of course, urinary tract infection, we all know, is a very common reason for seeking medical care. 50% of females will have greater than one or greater UTIs in their lifetime, 8 million office visits per year, 1 million hospital admissions per year, 7 million cases of cystitis, 250,000 of those might go on to become pyelo. So of course, urinary tract infection includes cystitis, by far and away the most common, pyelonephritis, urethritis, okay? So that's the spectrum of urinary tract infections. Bacteriuria, of course, just means bacteria in the urine, doesn't really imply an infection necessarily. That can be symptomatic or it can be asymptomatic. And then complicated urinary tract infection versus uncomplicated urinary tract infections. Again, uncomplicated being the most common. It's your woman of childbearing age with frequency urgency dysuria, and that's pretty much it. That's uncomplicated. Everything else kind of falls into the complicated section. So clinical manifestations, I'm not going to spend too much time on this, but of course infants can't tell you they have frequency urgency and dysuria, so they mainly not thriving very well. They may be having some vomiting, they may have some fever, they may have other non-specific issues. Children, as they be able to verbalize things better, they may be able to tell you about frequency urgency dysuria. And even flank pain or abdominal pain if that's what they have. Adults, at least for cystitis, we're looking for that frequency urgency dysuria. That's the triad. Turbid urine might be there as well, suprapubic heaviness or pain. Blood in the urine, hematuria, or pus in the urine, pyuria. For pyelonephritis, you sort of had those things as well, but you throw in flank pain and fever and chills as well. Might lead you to believe there's pyelo. On the elderly, symptomatology is somewhat problematic. May be asymptomatic. Pyuria may be absent. Typical symptoms may occur. Mortality from bacteremic UTI is pretty high, so you don't want to miss these. But it's somewhat more difficult to pin them down as far as clinical manifestations. Etiology is fairly straightforward and consistent, uncomplicated. It's E. coli, E. coli, E. coli. 75 to 90% of the time it's going to be that organism. Others that may be involved, including Staph saprophyticus, Klebsiella, other Enterobacteriaceae, Enterococcus, and Pseudomonas occasionally. For complicated or healthcare associated infections, E. coli drops down a little bit, but is still the most common organism. Other Enterobacteriaceae might be in higher abundance as well. Pseudomonas, Acinetobacter, Enterococcus, and Staphylococci can be players in addition. For the elderly males, seems like Proteus and Providencia actually outnumber E. coli a little bit, but E. coli is certainly in there along with Pseudomonas. E. coli is still number one for females, and Proteus and Klebsiella round that out. Anaerobes rarely cause urinary tract infections. If you suspect that, you want to collect a suprapubic aspirate, not a clean catch sample. We'll talk more about collecting specimens later. Salmonella, if that grows out of the urine, you want to be looking for bacteremia associated with that organism as well. Candida, associated with indwelling catheters and antibiotic therapy. Staph aureus usually gets to the urine by invading the kidney from the blood, so you ought to be thinking along those lines if you isolate Staph aureus. And coagulase negative staph, not usually considered a top urinary tract infection pathogen, but males with structural abnormalities can be infected with that organism. There's some rare organisms, not going to spend a lot of time on these. You'll find them in the literature where they can occasionally cause urinary tract infection. We'll point out that Candida is often healthcare associated, patients with diabetes, neoplasms, and then the quantitative criteria for the urine cultures does not apply to Canada, and we'll talk about that later. So, as far as laboratory diagnosis, you need an indication to do this. As Dr. V kind of mentioned earlier, and rightfully so, you need to have a patient that's symptomatic. But even in some patients, like again, the healthy females with frequency urgency dysuria, overwhelmingly the most common situation for UTIs. You know what the bacteriology is going to be. It's going to be E. coli. So you pull out your handy antibiogram and you pick a drug that E. coli is usually susceptible to, and you don't necessarily need a culture in that situation. For other situations, pretty much everything else, you probably do want to get a culture because the bacteriology isn't quite as certain. There may be more resistant organisms in there, so you want to probably do a culture in that situation. So if it is indicated, symptoms, whatever, you should do a urine culture outside of the exceptions that I mentioned. Results can aid in management. If that's going to be the situation, then by all means do a urine culture. If it's not indicated, okay, that yellow stuff coming out of the patient's got to be cultured. Okay, if that's the only reason, don't do a culture because good chance you're going to have a positive culture, even if there is no infection. And then what are you going to do? You're going to, yeah, there it is. There's a report that says E. coli. What are we saying in the laboratory when we put out a report E. coli and a susceptibility? We're saying this is a pathogen, treat it with this drug. Okay, that's the message. We're not saying that in so many words in the lab, but that's the message that goes across. So if you have a positive culture from a patient that didn't need a culture, the result is going to be antibiotic therapy with all the negative aspects when it's not needed that we've heard about already today. C. difficile infection, for example. I'll throw in antibiotic resistance. So we're treating organisms that don't need to be treated, and the antibiotics are getting in the GI tract and elsewhere. Those organisms are going to be exposed to the antibiotic, and they may become resistant as a result. So if it's not indicated, don't do it. Now, if you're uncertain about it, which shouldn't happen too often, we do have, and many labs offer, a urinalysis with culture if indicated. So there are many criteria out there for how laboratories decide this. When I first came into CHI, they were culturing it if it had pyuria. They were culturing it if it had nitrites in there. They were culturing it if it was turbid. They were culturing it if it smelled bad. They were culturing it if they felt like it, okay? So most of those got cultured, all right? We changed that and we're now at 10 white blood cells per high power field or greater. It's pretty stringent criteria. It's not perfect by any means, but that's when it's going to get reflexed over to culture. Now, you could order it as a culture. You can order it as a UA by itself together, okay? Or you can order it this way. We don't require this particular way to order a urine culture, okay? Just so you know. Any other criteria other than white cells has very poor specificity. And white cells isn't the greatest either, but it's the best of the worst. Okay, specimens. First morning sample is what we want. Easy to say that, hard to do it sometimes. If you think about when you wake up in the morning, what do you want to do right away? You don't want to go to the lab and get a sample. You know, you want to take care of that. Okay, but that would be the best sample to get. Suprapubic aspirate is going to be the best gold standard sample. It is generally safe to do. It could be used for infants, some adults, pregnant females. If you want an anaerobic culture, as I mentioned, how many of those do we get? Not very many. Okay, so I understand the reluctance to do that, but it is a good sample. Straight catheter to collect a urine, in goes the catheter, collect a sample, and out it comes. You want to discard the first few mils of that sample, use aseptic technique. There is a small risk of introducing organisms into the bladder with that, but generally considered a very good sample as well. Probably one of the worst samples we get are these pediatric bags. I'll show you a picture in a minute. Remember, we can't really do this very well on infants, but this is one way to do it. If it doesn't grow anything, I guess that means that's a pretty good answer. But if positive doesn't mean much, probably usually due to contamination. Foley catheter, okay? So use the collection port, clamp the tubing, don't collect the sample from the bag at all, and we don't culture the catheters themselves when they're removed either. And then, very important, if the patient has a Foley, you need to make sure that's a recently inserted Foley, no more than 72 hours old. Okay? So infection here in this setting is a CAUTI, catheter-associated urinary tract infections, and that's the bane of infection prevention. We don't really want those. Now, at our institution, we do, at the laboratory, we'll call for inpatients, at least at Center-Bergen, we will call the floor when we get a catheter, Foley catheter sample, and ask them, has this been a catheter that's been swapped out recently? Is this a culture you really need? And then a code P is what we call it, is initiated, and then people like Dr. V or other infectious disease folks get called, and they will kind of triage whether or not that urine is really needed to be done. Again, a lot of times these things are not done when they need to be done. They're done for other reasons. So there's some images of a straight catheter, a Foley catheter, a suprapubic aspirate in progress. And there's your pediatric bag on the bottom there. You can see how that, this urine is just going to slosh over all over the place, and maybe some will get in the bag, and it'll have all kinds of things in there. Okay, so the most common sample we get, of course, is a clean catch midstream sample. Collection technique is critical here. How many are nurses out there? Okay, you nurses are like the front line here in instructing the patient on how to do this. So cleanse with a towelettes as follows. Males, hold the foreskin back, clean the urogenital meatus. Females, separate the labia, clean the urogenital meatus, keep the labia separated while collecting the sample. So critical, okay, to do that. So of course the clean catch part of it, midstream part of it, is you urinate a small amount in the toilet and then catch the midstream sample. That first stream of urine is flushing out the urethral organisms, hopefully, and getting them out of the way, and then the midstream is going to be more representative of the bladder. Put the cap back on the cup and send it down to the laboratory. So urine is like broth media for bacteria. Okay, they will grow just fine in broth media. So you sit that urine over here on the bench and you let it go at room temperature for an hour or two. We've been through now 3, 4, 5 generation times of bacterial growth. They've doubled their numbers, 3, 4, 5, 6 times. So now when this urine might have been a negative, if it sits around for a couple hours at room temperature, it's going to be a positive urine. And then we have antibiotics, we have C. difficile, we have antibiotic resistance. Same issue, okay? So if you can't get it to the lab within 2 hours, put it in the refrigerator, not a food refrigerator, okay? It can be in the refrigerator for 24 hours. There's borate preservative tubes that work very well. Keeps the colony count stable. It doesn't have to be refrigerated. The key there is to make sure you got enough urine in the tube, but there's a little line, it's got to be up to the line or a little higher for it to be okay. Otherwise the concentration of the borate is too high and it kills organisms. So here are your urine cups with towelettes. So on the right is the borate preservative tube. So the cup looks similar, but if you take that yellow sticker off, there's a needle assembly in there that after the patient pees into the cup, you put the 2 tubes that are to the right of it on top. You puncture the rubber septum with the needle, and it draws the urine into the tube. Pretty nice. All right, screening methods. Now, you think, okay, urine is the most common sample we get by far in the laboratory, hundreds every day, okay? So there's been a lot of thought, well, how can we quickly screen urines for the ones that are going to grow something versus the ones that are probably not going to grow something? Many things have been tried. You heard earlier about bioluminescence with ATP. They tried that for urine specimens back when I was a postdoc a million years ago, previous century. It didn't. So all these things work fairly well if we're talking about a urine that's ultimately going to grow 100,000 organisms per mil. Not so much for any other situation, okay? So pretty much nobody does these anymore. Of course, the microscopic or dipstick UA is still done very often. So let's talk about that. Everything on the urinalysis is non-specific, okay? It may suggest certain things, but it's not meant to be a screen for urinary tract infection, let's put it that way. If you're looking for abnormalities in the urine because of other conditions, fine, but it's not really meant to be a screen. So there's a little pad on there that helps you with the pyuria thing, that's the leukocyte esterase, and it should be positive if there's around 5 white cells in there per high power field if you did a microscopic on it. So sensitivity and specificity at the 5 level, which is not what we use, but at the 5 level is about in the 80s somewhere as far as predicting urinary tract infection. So the reflex situation I mentioned earlier, any abnormality in the UA that we see reflexes first to a microscopic UA, then that's where we get the 10 white cells per high power field. Okay, so we don't rely on the leukocyte esterase. It has to be reflex to a microscopic UA, and then if we see greater than 10, we culture it if that's the way it was ordered. Okay, nitrites in the urine usually are there because there are bacteria that reduce nitrates to nitrites. Pretty much all the Enterobacteriaceae, E. coli, all those organisms do it. Some don't. Nitrites in the urine sort of suggest the presence of bacteria. So the sensitivity and specificity there are shown, again, not very good. Leukocyte esterase plus nitrites, sometimes some people have done that, either being positive. Sensitivity and specificity, again, still not very good. Other things, hematuria, proteinuria, bacteriuria, neither sensitive nor specific. Okay, white cell cast sometimes suggests pyelonephritis. So there's your dipstick UA and your microscopic exam for bacteria and white cells. You might say, well, if bacteria are present, that's suggestive of a UTI. Well, no, not really. We can get vaginal organisms in there, rectal organisms, skin organisms could all be in there as contaminants, and especially if the specimen sat around a while. All right, so do a culture. If you're going to do a culture, you must have symptoms, okay, of urinary tract infection. Frequency, urgency, dysuria, fever, other well-established indications. Now, pregnant females, that would be one indication for doing a urine culture in an asymptomatic situation. Prior to urologic surgery would be another, but there's not too many other reasons to do a urine culture outside of that, okay? So, what about normal flora? Well, urine in the bladder is supposed to be sterile. There's some literature in there that says, well, maybe not. I'm not sure I believe it yet, but we'll see what happens as things move forward here. But it should be sterile. Now, urine in the cup is not necessarily sterile, okay? It's got to go through things that may contaminate them. So we may have urethral flora in there, rectal flora, vaginal flora. Somewhere around 6 to 38% of samples will have organisms in it, okay, that are normal flora. These may include things like E. coli and Enterobacteriaceae. That could be causes of urinary tract infection, okay, but they're contaminants in that setting, okay? So if culture is performed without indication, just to hit that point again, growth is a good possibility. Unnecessary treatment will follow. C. difficile may follow after that, and maybe antibiotic resistance. And you get increase in CAUTI cases if the patient's got a Foley. All right, so these are some of the guidelines we kind of follow. If you have a symptomatic situation, 1 positive urine culture is good enough. If you have an asymptomatic situation before you start believing that this is real, you probably want 2 that are positive, okay? So we have non-invasive samples, things like clean catch, Foley samples, PD bags. We culture about 1 microliter of those. If it's an invasive sample, suprapubic aspirate, straight cath, we culture 10-fold more volume. Reason being, we want to be able to pick up lower colony counts. Media is really designed to pick up monomicrobial, gram-negative urinary tract infection. Yes, there are other organisms. Sometimes we get more than one, but that's what the design is because that's the most common situation. Okay? Now, interestingly, there's some chromogenic media, I'll show you a picture in a minute, out there where E. coli will be purple and Staph aureus will be red, and we have colors that show up on the chromogenic media that kind of tell us what the organism is going to be. Not cheap. So a blood agar plate is 15 cents. A chromogenic media is $4. So if you think of hundreds of urine cultures coming through, if you did them all by chromogenic media, all of a sudden a urine culture is the most expensive thing you're doing. So they get incubated, and then we start looking at those at 18 hours. We don't let any grass grow under our feet, okay? And we'll talk about more of that in a minute here. Okay, so quantitative culture is what we do. We get a colony count. So the colony count historically has been used to separate true urinary tract infection, classically 100,000 organisms per mil or more, from contamination less than 100,000 organisms per mil. Those studies were done on patients with pyelonephritis, not cystitis. So other studies that have come out recently that said lower colony counts can be significant, okay? Culturing as the test of cure, don't do it, okay? Except maybe for pregnant women or high-risk patients. So here's some of our charts that we use in the lab. So if we have a situation where we grow one organism, this is good, it's only one organism. If it's less than 10 to the 4, we don't work it up, but we'll tell you what it is just from colony morphology and quick tests. It may not be a definitive identification. If it's greater than 100,000, it'll get a full identification and susceptibility testing, okay? If there's two organisms, they're both less than 10,000, we don't, again, do kind of the same thing. If they're both greater, we do ID and susceptibility. If there's 3 or more, if there's one of them that's greater than 10 to the 4, we'll work that up, but not the others. Any other combination, we don't work up. It's a mixed culture. It's contaminated. It will not be worked up. Okay? Guess my talk's over now. Any questions? So, I mean, that's a non-diagnostic sample, okay? I get calls all the time, well, can you work that up because so-and-so and this and that, and so it's a non-diagnostic sample. It's contaminated. Okay, get another one that's better if it's indicated, is what we're going to tell you. All right, the invasive, everything is the same except 10-fold lower, okay, as far as the workup. So you just struck out so that we can count the colonies. Here's the chromogenic media. You can see the different colors indicating the different organisms. Pretty slick, but again, not cheap. Okay? So problems with culture. Specimen collection is the biggest problem, the pre-analytical part. Females, infants being particularly problematic. Patients with chronic catheterization, they're going to be colonized with organisms. Symptoms may be hard to assess in that population. Significance of 6 to 8 organisms, what is the significance? Generally, we consider that a contaminated situation or colonization. Culture is positive without indications of doing the culture in the first place. That's a problem, as we've just talked about. Mixed culture, okay? If you collect the sample correctly, it's a clean catch sample, that should be less than 5% of your cultures. If not, then it could be up to 50%. And we're not going to waste a lot of time on those samples, okay, because they're contaminated. Okay, so nursing home patients, a lot of urine cultures from nursing home patients, very poor positive predictive value absent some of the indications we talked about. For symptomatic patients, we can sometimes get less than 10 to the 5 organisms per mil, and it could be a true urinary tract infection if you look at some of the data that's in the literature. 100,000 organisms is about 50% sensitive, very specific, but only 50% sensitive, so it misses 50% of cases. 10 to the 2 gets most cases, but is less specific. So this is the common laboratory issue. When you adjust your breakpoints, you're going to increase specificity and then decrease specificity, increase sensitivity at the cost of specificity, or vice versa. Pregnant females with group B strep, just to mention that, that's a marker of heavy vaginal rectal colonization, and that needs to be always reported. Okay, false negative cultures, forcing fluids. You're drinking a lot of fluid to deal with the urinary tract infection, you may dilute out the bacteria. If you're on antibiotic therapy, most antibiotics are eliminated through the renal system and they achieve very high concentrations in the urine, so that could give you a false negative culture. Sterile pyuria. So you got pyuria, but nothing is growing. Well, there's a lot of reasons all on the slide here that tell you why you might have pyuria in the absence of an infection. And then it may be an unculturable organism, or the one that is not cultured easily given the media setup that we do. All right, so we get a positive culture, then what happens? So of course we identify it and we do susceptibility testing on it, because that's the whole thing, right? So if we get no growth, that goes out fairly quickly and we're done. If we do grow something, we need to figure out what the name of the bug is. That helps us with the clinical significance of it. So coagulase negative staph might be considered a contaminant, whereas E. coli would be considered a pathogen, and might help in picking therapy with just the ID. Conventional methods for doing identification, microscopy, colony morphology, biochemical reactivity have all been done for decades. Turnaround time there is 1 to 3 days after the appearance of the colony, which is day 1. So here's some of those things that we do. Gram stain, look at the colonies, do biochemical testing, all kinds of things that take a day or two to get done. Nowadays, we have a faster way of doing this called MALDI-TOF. So that's matrix-assisted desorption, ionization, time of flight. It's easier to say MALDI-TOF. So just say that. So this basically shoots a laser at a smear of the organism on a slide. It kind of blows it up, ionizes it, and then kind of smells the fumes that come off and determines what proteins are there, and we'll plot those. I'm oversimplifying, okay? So you get kind of a spectrum of protein peaks that come off, and that pattern is compared to a database, and you get the name of the organism. There's a number of different manufacturers. 10 minutes to do. And it costs 50 cents. Now the machine's $250,000, but we won't talk about that part of it. So there it is, and you get the protein patterns, and the key there is the database is good, and we get that ID in 5 minutes, 10 minutes. So then comes the susceptibility part. So when do we do susceptibility testing? We do it when the organism is clinically significant. As far as we can tell, it's a pathogen. Also, the susceptibility pattern must be unpredictable. We don't know necessarily what it's going to be susceptible to. And we have a standardized method for performing the test and interpreting the results. Those 3 criteria must be satisfied before we will do a susceptibility test, okay? So, utility, susceptibility testing results, in and of themselves do not guarantee clinical efficacy if it's susceptible. There's many other factors that are involved, okay? On the other hand, if it's resistant, probably isn't going to work. Don't use that drug, okay? So we want to make sure we detect resistance. Conventional way of doing this, again, about a day, okay? But more and more we're seeing rapid antimicrobial susceptibility testing methods come out. Vitec has been around for many years. It takes only 6 to 12 hours to do, and we have a Vitec. Now we're seeing more methods coming out, microscopy-assisted susceptibility testing, 2 to 4 hours, accelerators out there that will do certain organisms against certain drugs, 7 hours. So the whole idea is to get faster time to definitive and directed antimicrobial therapy. So how do we exploit this in the laboratory? Faster turnaround's nice, but you need to work at maximizing that advantage. If you just do everything kind of the way you were before, you're not really going to get the benefit of that faster turnaround time. So what we do is we read those cultures at 18 hours. We don't want to read them any earlier than that, okay? If we have no growth, the urine culture gets finaled right then and there. It's done, okay? If there is growth, we do the MALDI ID and the rapid susceptibility test. So we have the ID result in a few minutes, figure an hour. Okay, and the susceptibility results come 6 to 12 hours later. So we're the pitcher on the mound, and we've just thrown the pitch. Someone's got to catch the ball. Okay, that's where antibiotic stewardship comes in. Organism identification on day 1 instead of on day 2. That's the benefit. Reported susceptibility test on that same day rather than the next day. Clinical utility of fast results depends on what happens then. Okay? Is that information acted on? Okay? And how fast is it acted on? Stewardship intervention is vital to optimize that whole process. It doesn't matter if we report all that stuff faster if no one's looking at it until tomorrow anyway. Okay? So stewardship, we're providing the tool for stewardship to really optimize therapy. If they do, what's the impact? Shorter time to ID and susceptibility can give you, in conjunction with stewardship, shorter time to effective therapy, shorter time to optimal therapy, reduction in length of antimicrobial therapy, reduced length of stay, reduced ICU stay, all of which have been shown to occur with fast ID and susceptibility in the literature. So, just to summarize, key features of laboratory diagnosis. Perform only when indicated. Appropriate specimen collection and transport is vital. Garbage, if I get garbage, I can't make garbage into gold. It's going to be garbage coming out, okay? Awareness of the limitations of a urine culture, okay? And rapid ID and susceptibility with robust AS antibiotic stewardship can have significant clinical impact. I'm happy to take questions at this point.